Hi everyone, this is Neel Raithatha here, consultant audiologist and director of WAXscope. Thank you for joining me in my latest video using the WAXscope. And here we have a patient who impacted this wax right up against their eardrum and they were in severe pain, so they're experiencing otalgia upon attending. The anterior canal wall in particular is quite prominent and it is slightly red, so a bit of erythema there, no doubt caused by the misuse of the cotton bud. So we had to tread very carefully with this procedure because when a patient is already experiencing pain and they're tending to have their earwax removed, of course we're inserting instruments into their ear canal which can potentially exacerbate their pain. And so I immediately instilled some medical grade olive oil spray into this ear to soften the lateral surface because it is quite flat and also quite dry. It's very difficult to get a good suction grip to extract this. And just by softening the surface, sometimes you can soften it enough whereby you can obtain a satisfactory suction grip to eventually remove this. It is matted as well. There's a few hair strands sitting on the surface of this impacted wax, and there's a lot of skin involved as well, dead skin, keratin, which can make it a bit more difficult to get that suction grip. And also with the oil, if there is an opening, I think I just put some more in there because I lifted the plug from the floor of the ear canal. It will just allow a bit of oil to creep through, hopefully lubricate the canal wall where this wax plug is impacted against, and also travel up behind the wax plug against the eardrum to just help soften it and lubricate it so I can release and extract. Now, because they've got a very prominent anterior canal wall, and what I mean by that, this is the patient's left ear. If you look on the left-hand side, you can just see their canal wall there, and you'll get a better idea post-procedure. Beyond that point where the ear canal is protruding out, the ear canal sharply veers back to the left, which actually meant that I was not able to visualize this patient's anterior aspect of the tympanic membrane, the eardrum, using the WAXscope. So the only way you're going to visualize that is by an endoscope, where you're inserting the tip of the magnifying lens into the ear canal itself, so you're able to meander and sometimes almost visualize around corners. And I can confirm that the anterior aspect quadrant of their eardrum was fine and healthy post-procedure. So the difficult bit here is to dislodge it from that anterior recess. So that cavity that's created by the anterior canal wall protruding outwards into the middle of the ear canal, and then veering back off to the left, is that it's called the anterior recess, and we're going to try and dislodge that from that region. I'm just going to the top of the ear canal, and now initially the patient said they didn't use a cotton bud, but there's a few woolly strands in there, and it's not hyphae from otomycosis, a fungal infection, and you're not going to get it this impacted without using a cotton bud. Now, you could argue is this keratosis obtrans, but it's not, because you don't have that white peripheral silvery matrix, which is common and almost synonymous with the keratosis obtrans extraction. And also, although there's a slither of skin here, the rest of it, you don't have that same texture of keratosis obtrans, where you have a lamellar structure where all the stratum corneum dead skin cells, so the epithelial skin cells, are interconnected and woven. So it just didn't have that appearance, texture. In addition, there was no bony remodeling of the ear canal, which is again a characteristic of especially grade 2 and above keratosis obtrans. The only symptom that this patient was exhibiting and clinical finding that resembles a keratosis obtrans, that they were experiencing earache, ear pain, but that was more in relation to the use of the cotton bud pushing this right up against the eardrum. So you can see it's lifted off the floor of the ear canal. I release some of the plug superiorly, where there's a bit of skin attached. Now that skin was acting like double-sided sticky tape. It was not only adhered to the canal wall, but enveloped around this plug, so we separated that. It's very difficult using manual instruments for two reasons, I would say, in this, well, maybe three reasons. The first is that when you're so deep into the ear canal, onto the osseous sections of the inner two-thirds, the ear is highly sensitive. And because this impaction is compressed against the canal wall, inserting a manual instrument like an ear hook or a correct, or even trying to glide the forceps, so there's a bit at the bottom there that's protruding outwards, you're going to come in close contact with the bony part of the ear canal. I would say you're probably not close, you would come in contact, which is going to be really uncomfortable for the patient. And because they're already experiencing otalgia, pain, ear pain, I'm just going to try and remove this using suction. Also, space is limited because of that prominent anterior canal wall. So we just don't know how prominent it is beyond the wax plug. So if I get the hook in and behind and pull it out, the tip of the hook as I'm extracting it could easily graze that anterior canal wall. So we're making slow and steady progress. We can see this is slowly coming away. And just had to be patient with this one. And just giving it little wriggles. With a plug like this, because it's so hard to get a suction grip, you have to almost hover the tip of the suction probe onto the lateral surface and not come away too quickly. If you come away too quickly, you're going to lose that suction grips. And you not only get a kinesthetic feel of that tip making contact with the lateral surface of the plug of wax, but with our suction machine, it becomes quieter. So the stronger the suction grip, the quieter the suction pump becomes. So there's a audible telltale sign as well. So as I'm lifting this, prising it away from the canal walls, I'm just putting some more oil in. So of course we're going to check the pipe in oil. We're going to take a patient's otological history just to make sure they've got no contraindications to using any ceraminolytics, which is the medical name given to earwax softening drops. The most common ones is if they've got a perforation or active infection or a ventilation tube, so what we call in the UK a grommet, which this patient didn't. So again, the periphery of this, there's a lining of skin. So I'm just separating that. So it probably brought this forward by a centimetre. So the average ear canal length is about 2.6 centimetres. So we've still got a bit of a way to go before we fully remove this. But this plug is defragmenting now. I'm taking little slithers of skin and making the plug smaller. So the smaller we can make it, just by removing the outer layers. If you think about an onion, if you take the outer, the layer by layer, as you remove the layers of the onion, the core becomes more present. So the onion itself, the overall diameter decreases, which in the case of the wax plug, the smaller we make this, the easier it is for me to pull out the ear. So I'm just going to the top of the ear canal there, just giving little wriggle movements to just break this down a little bit more. So we're nearing the second bend. So this, the most lateral set of the wax plug that you can see here, it's probably about a centimetre away from the eardrum now. I'm just trying to get a suction grip from the top. So I've got a double suction grip. I had a grip on the right hand side of the skin and then also the top where the plug is itself. And as I'm wriggling it, I'm bringing it upwards to release it from the inferior recess. So not only do we typically have a widening of the ear canal adjacent to the eardrum on the left hand side, but there's almost a ditch at the floor of the ear canal just in front, adjacent to the eardrum. So by lifting the plug upwards, you're taking it out of the inferior recess. Now I'm using our medium-sized speculate. It was quite a narrow ear, but after I dilated it and inserted the suction probe, it was a good fit. Because they've got this prominent anterior canal wall, we've got to make sure we don't over-insert the specular. Now, the specular can only go in so far. It's a tapered, flared end, which prevents over-insertion. Could have also used a smaller specular, but just get a slightly better visual with the bigger specular. So it's coming away in little pieces now. So yeah, I'm just trying to look for that part of the plug where I can get a good suction grip. So I've got one here. You can see those hairs that are matted. So these hairs were originally from the outer third. You can see them there at the top of the screen. So these hairs should only form on the cartilaginous outer third, where you have hair follicles rooted into the dermis layer, which is the middle layer of the skin. The most superficial layer, the outer layer, is the epidermis layer. So the bony part of the ear canal only contains the epidermis layer of skin. It doesn't contain the dermis. And then there's, in the cartilaginous portion, there's a hypodermis or subcutaneous layer of skin, which is predominantly made up of adipose fatty tissue. So the skin is a lot more thicker in the outer third of the ear canal. Now, there's just some crusted skin here. I'm going to just remove this. I just want to make sure there's nothing lurking underneath. And sometimes hidden underneath, especially inferiorly, you're more prone to seeing benign osteonecrosis. This patient was quite young, so very unlikely you're going to have that. And again, being young, less likely to have a canal cleftriotoma, but sometimes you can get an ulceration due to a pressure necrosis, where the plug is so compacted against the canal wall, the pressure itself causes an ulceration of the skin. So I just want to, it's not necessarily trying to peel this away, I just want to reveal what's underneath. And I did pre-warn the patient here because it's really crusted skin. On quite a few occasions in recent times, when I remove this, I see an ulceration and the underlying bone is exposed. Now I'm using the 16 gauge suction tips. So predominantly we use a 14 gauge, that's a standard Zollner dimension. Then the fine end is an 18. Now this is a 16, so it's in between. So it's a lot quieter for the patient, but it's got more suction power than the 18 gauges is what I need there. So I'm happy with that. I lifted that crusted dead skin, getting a bit of clarinetting, so we stop. So you can see just how red the anterior canal wall is. You can see the eardrum to the hammer bone, but we're able to visualize beyond that afterwards. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.